Hi everyone, welcome back. We are now at the last lecture in Block 2, the last lecture of Chapter 17 and our coverage of blood. But remember I said that blood was the kind of central theme underlying this entire course. So absolutely everything we have learned in this block is going to stick around, and then when you go on into your programs and into your profession, everything from this chapter is still going to be incredibly important. So make sure that anything in this chapter, in this block, if it's not clear, make sure to get it cleared up because it will not go away. So before we get to our not really attendance questions, I thought I would start this lecture off with a little bit of interesting factoids here and tie it into this pretty graphic picture that we're looking at. What we're looking at here is the results of a disorder called dracunculiasis, or guinea worm disease, and that white stringy thing, that is something called a guinea worm. And this is really in only one very small part of Africa, but there it is pretty prevalent. And the way that this disease or condition spreads has to do with dirty drinking water. Well, in the spots where the people that live here go to get their water, large lakes and ponds, rivers, there are these small little insects called water fleas. Now, water fleas, part of their diet is guinea worm eggs. They eat these eggs, and then the guinea worm eggs are in the fleas. Well, when someone goes to this water source and scoops up their water for the day, some of these very small water fleas are there. And when they drink their water, they drink some of those water fleas. In their stomach, those water fleas are digested. But those eggs then hatch, and the infantile guinea worms are now inside this person's digestive system, and they burrow through the walls of their digestive system and get to their muscles, their skeletal muscles, and they live there for 3 years or so. And when they're there, the females will mate with the males. The males don't really do much, they tend to die off. But once the females are fully mature and ready to lay their eggs, by this point, they're anywhere from 3 to 4 feet long, living inside your muscles. And then they will start to migrate downward, usually towards the feet. Sometimes they do end up in the hands and wrists, but usually towards the feet, where they end up at the top of the foot, the bottom of the foot, or around the ankles. And you start to have this incredible pain right where the worm is. And the only thing that will alleviate the pain is soaking it in water. So this person goes back to their water source, dips their feet or their hands into the water, and when they do that, the worm notices, and that's what causes it to burst through the skin like this. And when it bursts through the skin, it releases its eggs, and the cycle starts all over again. So what do you do if you've got this worm? Well, like I said, it's about 3 or 4 feet long. And worms are pretty soft, and they like to stay kind of where they are. So when it bursts through the skin, you cannot just grab it and pull it out. All that will happen is the part of it that you grab will break off, and the rest of it will still be in there and probably cause an even worse infection because now it's dead. So as it pokes through, you get a stick, and you gently wrap the exposed portion of the worm around the stick. And each day, as the worm emerges a little more, you wrap it a little more around the stick. This prevents it from pulling itself back into the body, but it doesn't apply enough pressure that it breaks the worm. So over the course of several days, you are winding this worm as it comes out of your body. Now, that sounds pretty traumatic. And like I said, it's only in a very small part of Africa. But it is actually on track to being the next fully eradicated disorder, because there's something that a lot of us might be familiar with called the life straw. And this is something that looks kind of like a straw. It's got a lot of filters in it. You put it down in water on one end and you drink through the other end, but it filters everything out, including these water fleas. So if you get rid of that step, then you can get rid of this dracunculiasis guinea worm. One more thing to do with this before we get to our not really attendance questions, and that is this. We've all seen one or both of these, the caduceus staff or the rod of Asclepius. And these are to do with medicine and healing. And if you've ever thought that it was kind of weird to have this snake around a pole to do with healing, well, there's a reason behind that. They believe, this has not been completely verified, but they believe that what this is actually depicting is not a snake wrapped around some sort of rod, but it is a guinea worm wrapping around a stick as the healer is helping pull it from the body. So, like I said, that's not been completely verified, and it's nothing really to do with anything that I'll ask on an exam, but I thought it was just an interesting fact that you all might think was interesting also. So with that said, let's go on to our last lecture of this chapter of this block and start with our not really attendance questions. First, based on what we just talked about, what would have been elevated in that scenario? Next, what are formed elements? And third, what makes erythrocytes and platelets different from the other types of formed elements? So go ahead and pause your video and try to answer those. Hopefully you've done that. So let's see. Based on that guinea worm scenario, what would have been elevated? Well, obviously anxiety and pain and stress, but that's not what we're talking about. What's something that we could measure? Well, if we did a blood draw in someone, we would see that they have elevated eosinophil count. Remember, eosinophils are the leukocytes that respond to parasites, such as parasitic worms, like we just saw. Next, what are formed elements? Formed elements are the parts of blood that are cellular in origin, so erythrocytes, platelets, and leukocytes. Red blood cells, white blood cells, platelets. And what is it that makes erythrocytes and platelets from what makes them different from the other formed elements? Well, erythrocytes and platelets are not true cells. Remember, erythrocytes eject their organelles and their nucleus. Platelets, we said, were just little flecks of cells. So today, we're going to look at platelets. What are they and how do they work? So platelets, remember every word or every cell that we've talked about so far, we've learned a different name for them. We said red blood cells we're going to call erythrocytes from now on. White blood cells we're going to call leukocytes from now on. And platelets we are now going to call thrombocytes. Platelets are thrombocytes. And in a microscope, they kind of look like flecks of dust. They don't really have much of an appearance at all, and that's because they are just pieces of a cell. So where do they come from? How are they produced? Like every other formed element that we've talked about so far, they begin with a hematopoietic stem cell, a hemocytoblast, the same stem cell that red blood cells and white blood cells come from. So erythrocytes, leukocytes, and thrombocytes all come from a hematopoietic stem cell, a hemocytoblast. When we are going to make thrombocytes, when we're going to make platelets, this stem cell divides. One of the two cells that results remains a stem cell. The other becomes something called a megakaryoblast. Mega means big, karyo means nucleus. So here is our megakaryoblast. Another name for this is a stage 1 megakaryocyte. Well, when we get to this megakaryoblast, we are going to start making ribosomes so that we can start making granules. So as those ribosomes increase in number and as we start making those cytoplasmic granules, we move into a megakaryocyte stage 2 and a megakaryocyte stage 3. We can see everything building up inside, those granules starting to build up. And eventually the cell gets very big and it starts to grow these long processes called pseudopods. And we are now a megakaryocyte stage 4. Megakaryocyte stage 4 starts to have pieces of it flake away, and those are platelets. So let's see another view of that. Here is that stage 4 megakaryocyte. Here is a real stage 4 megakaryocyte stained and looked at under a microscope. But here we are, this is inside of the bone marrow, and those pseudopods that we looked at reach into some vessels that are inside the red bone marrow. They are similar to very small arteries, but they are called sinusoids. Don't worry about that. I'm not going to ask about that. But those pseudopods reach into this vessel, and pieces of these pseudopods break off. And at first they're kind of big. We call them proplatelets. But very quickly they break off into very, very small pieces, and these are the platelets. So down here is a drawing. Up here is the actual megakaryocyte stage 4. Here's that pseudopod, and then we can see some large pieces broken off here. These are those proplatelets, and then very quickly, very small pieces break off, and these are platelets. The platelets now are going to be circulating in your bloodstream so that they can perform their function. So what is their function? Their function is to clot blood to patch wounds. So blood clotting, this is completely different from clumping that we talked about when we were talking about blood types. Clumping is agglutination, but clotting is called hemostasis, which is a completely different word from homeostasis. Homeostasis we talk about all the time. Hemostasis is blood clotting. You get a cut, the blood starts to thicken, and then eventually we form a scab. That is hemostasis. Now, hemostasis doesn't just occur when we cut our skin and we start to bleed. Hemostasis is something that's constantly going on in our body. We said that as blood circulates, for some of the cells there, it can be pretty damaging. That's how come red blood cells only live about 120 days. They don't have any organelles to patch up any damage that occurs to them. Well, that damage occurred because as they circulate, they bump against vessel walls, they go through very small vessels, and that's damaging for them. But it's damaging for your blood vessels also. When you move certain ways or when certain cells go through, it causes damage to these very small blood vessels. And that hemostasis process, the blood clotting process, occurs there also. If it didn't, we would die from internal bleeding. But it's happening all the time. And it's completely okay because this is how our body fixes itself. So let's look at the steps of hemostasis. you get some sort of damage to a blood vessel and surrounding tissue, but we're just talking about the blood vessel. You get some sort of damage to a blood vessel. What happens so that we're not constantly bleeding until we die? Well, as soon as that blood vessel is cut, like we see here in the top image, well, remember blood vessels, they have smooth muscle on the inside. We saw that back in Bio 137. There's smooth muscle inside of blood vessels. And when you damage smooth muscle, it responds by contracting. So here we have this blood vessel that's got a cut in it, and now that smooth muscle starts to contract. We call this a vascular spasm. Well, if this blood vessel contracts the way these arrows are pointing, it squeezes in from all sides, it's going to get a smaller diameter. Well, one, that's good because that lets less blood through, so we lose less blood. But at the same time, it squeezes this cut, basically squeezing it shut. Now that doesn't fix the cut, but it prevents us from bleeding as much. You're squeezing this hole shut. That's the point of the vascular spasm. And that's just a result of that smooth muscle contracting because of the damage that occurred to it. Now, next, we have something called the platelet plug formation. Here, when we damage a blood vessel and any surrounding tissue, that's going to expose collagen fibers. Remember, we saw a lot of collagen fibers back in Bio 137. They're in all of the connective tissue practically. So these collagen fibers are kind of sticking out like loose threads. Normally, the collagen fibers are hidden away. They're packed into that connective tissue, but we've damaged this whole blood vessel and the surrounding tissue. So those collagen fibers, some of them are exposed. And when we have those collagen fibers exposed, they're going to interact with a protein, well, it's actually more of a carbohydrate, that's in the plasma. It's called von Willebrand factor. Von Willebrand factor is always circulating in your plasma. And normally it doesn't do anything. But when collagen fibers are present, the von Willebrand factor and the collagen work together to make the platelets sticky. Normally platelets don't stick together. We don't want that. We don't want anything sticking together in our blood because it impedes the flow of blood. But as these collagen fibers are exposed, they and von Willebrand factor work together to make the platelets sticky. So platelets are getting caught in these loose collagen fibers and sticking to the collagen fibers. There's actually a chemical reaction that forms a bridge between the collagen fibers and the platelets. And since the platelets are now getting sticky because of collagen and von Willebrand factor working together, that causes the platelets to stick together. Now, here we're going to have a positive feedback mechanism. Remember, most feedbacks in the body are negative. We've talked about a couple so far that are positive. Here is another one. As the platelets stick to the collagen, and then more platelets stick, that's going to cause the platelets to release ADP, adenosine diphosphate. ADP causes more platelets to come to that area. And as more platelets come, what happens? They stick to those growing mounds of platelets. And as more platelets stick, more platelets release ADP. More ADP causes more platelets to come More platelets come, they get stuck, they release ADP, causing more platelets to come and get stuck, releasing more ADP. That is why it's a positive feedback loop. The more platelets come, the more they get stuck and release ADP, causing more platelets to come. All right, so as this is happening, we're having this growing mound of platelets. That's our platelet plug formation. We're going to have serotonin and thromboxane A2 chemicals being released. Serotonin is going to enhance that vascular spasm. It's going to cause the blood vessel to squeeze even tighter, squeezing this plug even tighter, and causing less blood to come to the area. Thromboxane A2 causes even more platelets to come to the area and get stuck in that growing platelet plug. So far, we've had the vascular spasm, and this is ongoing. It doesn't stop when step 2 starts. It keeps squeezing shut. But while that is happening, we have the platelet plug forming. And this is kind of like a band-aid. It's temporary, but it's better than just squeezing the vessel shut. So they're happening at the same time. The vascular spasm starts, and then the platelet plug starts to grow. But as the platelet plug is growing, the vascular spasm is still occurring. But we said that the platelet plug is temporary. It's not going to be a long-term fix. It's just throwing rocks in there to keep water from flowing through. It's throwing platelets in there to keep blood from flowing through. So we need a long-term fix. We need to actually fix that cut. And that's where we have the long-term fix that takes a little longer. It takes 3 to 6 minutes for it to really set in. And this is formation of a fibrin clot. So we're going to show this step by step with the flow chart. And a couple of things before we look at the flow chart. One, I'm going to present this very differently from our book. It's going to read differently. It's going to kind of take a lot of the steps and put them together so that there's not quite so much to remember. I'm summing it up in a way that there's less to remember, and I think it makes a little bit more sense. Now, the other thing that I want to point out is from this point forward, we're going to have a lot of flow charts. So it's important to understand what a flow chart is and what the different symbols represent. So as we go through and we see some symbols, I'm going to tell you what they mean. All right, and the way that I have these words written on here is going to be important. We'll see why as we go. Now, everything that we see on this slide is in our plasma circulating. And really, in most situations, as these things are circulating, they're not really doing anything. They're just there. And throughout this semester, we're going to see there's a lot of stuff in our plasma that is normally not really doing much of anything until certain conditions happen. These, the same thing. So the white background here is just to represent your plasma, and it's circulating through. Now, we see procoagulants. Procoagulants are things made by the liver. Some of them are proteins, some of them are enzymes, but they are collectively, we're just going to call them procoagulants. That just means things that aid in coagulation. Coagulation is the thickening of blood or the clotting of blood, similar to hemostasis. So procoagulants, these are things that aid in that. But normally, like I said, they're just there circulating. When you look in your book and you see all of those Roman numerals, that's what these procoagulants are. I've just added them all together. So we have procoagulants in our blood, in our plasma circulating. We have calcium. Calcium really all over our body, but calcium circulating in our plasma, Ca2+. and platelet factor 3, PF3. So these things are circulating in our blood. We also have a protein called prothrombin, and fibrinogen. Hopefully this word looks familiar. We saw it back when we were talking about plasma in the second lecture of this chapter. So procoagulants, calcium, platelet factor 3, prothrombin, and fibrinogen all circulating in our plasma, not really doing a whole bunch of anything. But when there is vessel damage, that's going to change. When there is vessel damage, we said that one, it triggers that vascular spasm. We said that it also exposes collagen. So those things are happening off to one side, but we're looking now at that long-term fix. When there is vessel damage and the vessels and surrounding tissue have damage to them, something called tissue factor is released. Tissue factor is something that is released from damaged tissue. If there is no damaged tissue, there should not be any tissue factor around. But when there is damaged tissue, tissue factor starts to build up. Now it gets into the blood and it circulates, but as it's circulating, it's being diluted, except for the spot where the vessel damage is. Wherever there is damaged tissue, there is a very high concentration of tissue factor. Now, we said procoagulants, calcium, PF3, platelet factor 3, they're not really doing anything. But when tissue factor is present because of damaged tissue, the tissue factor interacts with the procoagulants, the calcium, the PF3, and the result is something called prothrombinase is formed. So, the way that we read this is tissue factor from vessel damage. That's what this arrow means. The vessel damage causes tissue factor or releases tissue factor. Tissue factor plus these things leads to prothrombinase. Now, the way that we can interpret this is prothrombinase should only be there if there is tissue factor present. And tissue factor should only be there if there is some sort of damaged tissue. So the vessel damage releases tissue factor, which interacts with all three of these to produce prothrombinase. Now, you may or may not have heard from prothrombinase. Most people have not before this class. But if you knew nothing else about prothrombinase and you've never seen this word or heard this word before, I bet there's something that you could tell me about it. What do you think you might know about prothrombinase? I bet a lot of you are saying it's an enzyme, and we know that because it ends in ASE. Enzymes, not always, but almost always, end in ASE. Prothrombinase is an enzyme. Enzymes, remember, are proteins that cause a reaction to happen faster than it would have otherwise. And enzymes, when they do that, they themselves are not changed. They do not get changed by the reaction. The way we show this is with this symbol. This says prothrombinase causes a reaction to happen, but we are left with prothrombinase afterward. The prothrombinase causes something to happen, but it remains prothrombinase. It does not change. But down here, prothrombin is going through a reaction because of the prothrombinase. So, what is it that happens? Prothrombinase causes prothrombin that was just circulating in the plasma doing nothing, and it changes it into something called thrombin. Prothrombinase converts prothrombin into thrombin. So now we have thrombin building up. But prothrombinase is still hanging out. So, before we look at the next step, let's summarize some things. Vessel damage releases tissue factor. Tissue factor is building up locally where that damage was. Some of it's getting carried away, but it gets diluted as that happens. But there is a very high concentration of tissue factor at the spot where the damage is. And that tissue factor, when it builds up, interacts with these other things in the plasma. And we get prothrombinase building up. Where do we think that prothrombinase is going to build up? It's going to build up in the same spot where there is vessel damage. Some prothrombinase gets carried away in the blood and it gets diluted when that happens. But there's a large concentration of prothrombinase where that vessel damage was. And prothrombinase is taking prothrombin that's in the plasma and converting it into thrombin. So now we have a large concentration of thrombin building up at the spot where the vessel damage is. Some of the thrombin gets carried away in the blood and diluted, but most of the thrombin is building up where that vessel damage was. We also have prothrombinase still hanging out because it doesn't get changed when it does this. Only the prothrombin gets changed when it does this. So thrombin is building up where the vessel damage is. Thrombin, this one's a little bit tricky because thrombin is also an enzyme. It does not end in ASE, but it's still an enzyme. Well, what does thrombin do? It converts fibrinogen into fibrin. Thrombin is unchanged by that reaction. But thrombin takes fibrinogen. Remember what fibrinogen was? It was a protein in the plasma that was dissolved in the plasma. It was soluble. But fibrin is not. It is a long, stringy protein that is insoluble. So as thrombin converts fibrinogen into fibrin, well, we still have thrombin left over. It doesn't get changed. But as the fibrinogen converts to fibrin, it settles out of the plasma. It's a stringy substance. It's insoluble. And what's going to happen? Where is this fibrin? This fibrin is there where the vessel damage is. If this is this long, stringy fiber that's not soluble, and it's where the vessel damage is, what else is where the vessel damage is? Exposed collagen fibers, growing platelet masses. What do we think might happen? This fibrin is going to get caught here in this platelet plug and exposed collagen fiber. And it's going to essentially form a mesh or a net. And as that happens, the fibrin starts to dry out. It starts to solidify. It starts to form a net that's going to catch more platelets. But as that net builds, it's going to catch red blood cells. It's going to catch white blood cells. It's going to catch other plasma proteins. So essentially, we are covering up that cut and just throwing everything at it. And as this fibrin clot hardens and dries, it kind of patches up long-term that cut. But let's take a look backwards. This fibrin should only be there if thrombin is there. This thrombin should only be present if prothrombinase is there. Prothrombinase should only be present if tissue factor is there. And tissue factor should only be present when there is vessel damage or other tissue damage. So, vessel damage leads to fibrin, but fibrin should only be there if there is vessel damage. That keeps us from having blood clots when we do not want blood clots. But it also ensures that we get blood clots when we need blood clots. So here is a fibrin clot, and we could see the fibrin. We can see the erythrocytes. That is hemostasis. But once we've done that, once we've applied that long-term patch that can fix things, how do we actually repair the vessel and regrow damaged vessel? Well, the platelets also released something called platelet-derived growth factor, PDGF, platelet-derived growth factor. When this is released, it causes vessels to grow. It will cause damaged areas to grow, to replace or fix those damaged areas. In some cases, it can cause entire new vessels to grow. Interesting side note, cancerous tumors release platelet-derived growth factors. And that's because tumors, remember what tumors are? They are mitosis when we don't want mitosis. Well, because they're constantly going through mitosis, they need a lot of energy from the blood, and they need their own blood supply. So they will release platelet-derived growth factor, which causes new vessels to grow towards them so that they can get access to that energy. Unfortunately, we can't block that because we need platelet-derived growth factor to fix those damaged vessels that are constantly happening in our body. Well, there's a lot going on here, and there's, the chance that this can be runaway. What if that vessel damage keeps releasing tissue factor? Well, that's going to keep causing more fibrin to build up, and eventually it can block off vessels. So what keeps the clotting in check? Well, I kept saying that the blood flow carries some of those things off, and that's important. Normal blood flow carries away all of those different clotting factors so that they're building up in a small area, but it's not just building up all over the body. We keep circulating and we keep moving those factors away so that they don't just keep interacting with each other. Healthy tissue also releases something called prostacyclin and nitric oxide, and these things prevent aggregation of platelets. So let's talk about some disorders of blood clotting. Well, sometimes there is something called a thrombus, or if there's more than one, we call them thrombi. Thrombus is one, thrombi is more than one. This is when there is a blood clot growing on the wall of a blood vessel. If that thrombus breaks off and goes into circulation, that's called an embolus. Or if there's more than one, they are emboli. So an embolus is a circulating thrombus or a circulating blood clot. Now, blood clots, they're kind of big. They're not gigantic, but they're kind of big. And our blood vessels, the further and further and further we get away from the heart, the smaller the blood vessels get until eventually they are capillaries, which are microscopic. So the further you go away from the heart, the smaller the vessels get. Well, when one of these emboli gets caught in one of those small vessels, that can lead to an embolism. An embolism is when that blood vessel gets caught in a small blood vessel. Well, we've still got the blood trying to get through, so since these vessels are small, that means they have very thin, very weak walls, and that blood pressure will start to build and build and build, and the side of that blood vessel, the wall of it will start to distend or stretch outward and could eventually rupture. So how do you fix that? Well, we use anticoagulants. Anti means against. So anticoagulants fight against coagulation. One thing that we use is aspirin. Aspirin blocks thromboxane A2. Remember, that caused platelet aggregation. Aspirin is not a blood thinner. It just prevents blood clotting. So it can lead to a lot of bleeding if you get a small cut, not because your blood is thinner, just because your blood is not being able to clot. Heparin. Heparin blocks thrombin. And then lastly, warfarin, Coumadin, rat poison, these are all the same thing. It's just we call them different when they are a medicine or when they are just the chemical itself or when it is being used to kill a rat. They all are the same thing and they all work the same way. They prevent the liver from accessing vitamin K. Well, let's go back to our flow chart here. We said the liver makes procoagulants. It needs vitamin K to make procoagulants. So the liver pulls vitamin K out of our blood that we got from our diet. The liver pulls vitamin K out of our blood and uses it to make procoagulants. If we block vitamin K from getting to the liver, which is what warfarin, Coumadin, rat poison, that's what it does. It blocks the liver from accessing vitamin K. And if the liver can't access vitamin K, it can't make procoagulants, and everything past this point cannot happen. No procoagulants, we don't get prothrombinase. No prothrombinase, we don't get thrombin. No thrombin, we don't get fibrin. So the way that rat poison works is by preventing prothrombinase, which means that the blood can't clot. Well, remember we said we constantly have these small little micro cuts in our blood vessels. And if you don't have the ability to clot, you're going to bleed internally. And that's how rat poison works. Now, some people, they actually take warfarin, Coumadin as a medicine, which that's only if they have a clotting disorder. Sometimes there's some things that mimic tissue factor or that cause thrombin to be created when it shouldn't be. So they're constantly at risk of forming a fibrin clot. To prevent that from happening, they will intentionally take small doses of what is essentially rat poison. It's not harmful in that situation. It is if it's in a high enough dose, and it is if you don't need it. But that's warfarin, Coumadin, rat poison. They're all the same thing. They all work the same way. They block the liver from accessing vitamin K from our diet. And without vitamin K, we don't make procoagulants. Therefore, we don't have any of that flow chart happening. Now, one real quick thing. Sometimes I ask about this on an exam in one way or another. And people think that vitamin K is the same thing as potassium, because potassium K, or potassium ion K plus, well, they are not the same thing. Vitamin K is not potassium. Vitamin K is not potassium. All right, some other disorders. There's something called thrombocytopenia. See if you can work through what that word means based on root words that we've learned along the course so far. Thrombocyte, well, those are platelets. Penia, we've seen before. Leukopenia, back in lab. Thrombocytopenia is when we don't have enough platelets. If you don't have enough platelets, that can cause small little places where you bleed internally. And one way to know that this is happening is the appearance of something called petechia, which is what we see down here. You probably have some little red spots on your skin. I feel pretty safe in saying chances are those are not petechia. They are something else. Petechia, there tends to be clusters of them, and this is just bleeding under the skin. Impaired liver, so if you start to have liver failure, or a vitamin K deficiency because of diet or inability to uptake vitamin K or whatever, the result is the same. If your liver is not functioning, or if you don't have enough vitamin K in your body, well, again, that's just like rat poison. That is, you don't have vitamin K, so your liver can't make procoagulants. And lastly, hemophilias. Hemophilia is, again, I feel like a broken record now, it is not a disease or a disorder, it is a class of disorder. There are different types of hemophilia. But what they all have in common is the inability to clot. So it is very common for someone with hemophilia to have to get blood injections. And the point of that is to get some platelets into their body, or some fibrinogen into their body, or whatever part they are deficient in. They're getting injections. And I have a name down here. Every year it seems we're further and further away from this, but some of my non-traditional students who were alive in the 80s and can remember that time well, I'm sure they are familiar with the name Ryan White. Well, Ryan White was a young man who had hemophilia, and he went to get a blood donation. And this was at the time when the HIV/AIDS scare was just beginning. HIV/AIDS, it was a thing, but it was not getting very much attention at all. But Ryan White went to get an injection for his hemophilia, and it happens that the blood that he was injected with had HIV and caused Ryan White to get HIV/AIDS. And once this happened, then attention turned to AIDS very, very quickly, and that started the big part of the AIDS scare of the 80s. If you were around in the 80s and can remember that time, AIDS was a terrifying thing. Remember the COVID that we just went through? Well, most of the 80s was kind of like that with AIDS, because we knew that it was spreading, but at the time, not a whole lot was known about it. And it was kind of, we don't know how it spread. It started a lot of homophobia because it seemed to be somehow related to homosexuality. Like I said, at the time, we didn't know a lot about it, so it was just scary. But this brought the attention to it. And it also brought a lot of fear, but it brought attention to it, which is kind of a good thing because that meant money was getting thrown at it and we can learn from it. So this also caused a lot more screening in donated blood. Prior to this, there wasn't a lot of screening. After this, donated blood is screened very, very closely for all numbers of things. But Ryan White is the reason that a lot of attention was turned towards HIV/AIDS, and it all had to do with the fact that he was a hemophiliac, or a carrier of hemophilia. All right, so that brings us to the end of the last lecture of this block. So we're going to take our exam, and then we are going to begin chapters 18 and 19 The way that we're going to cover it is we do a little bit of chapter 19, blood vessels. We jump back and we do all of chapter 18, and then we jump forward again and do a little bit more of 19. So it's a little out of order, but that will be in block 3. Only blood is on the block 2 exam, plus a little bit of older material. All right, take care, good luck on your exam, and I'll talk to you in the next lecture.